Assalamualaikum warahmatullahi wabarakatuh. All right, let me get this started. So you are watching Breakfast at UMHealth, version 8 of March 2023. So today is a special Breakfast at UMHealth because it is celebrating the World Kidney Day of 2023. So this World Kidney Day is a day of celebration. It falls on the first Thursday of March every year. So this year, tomorrow, 9th of March, will be our official World Kidney Day. So people all over the world will be celebrating this, and you can see nephrologists in Malaysia almost every day in the TV and radio promoting World Kidney Day and awareness of kidney disease all around the country. So like last few years, this year, the renal unit of Department of Medicine have been given the opportunity to be on the Breakfast at UMHealth one day prior to the WKD. For this year, the topic is preparing for the unexpected, supporting the vulnerable. So the topic is huge. So we decided that to focus, this year we're going to focus on one of the vulnerable group in Malaysia, the HIV patients. So despite many advancement of HIV throughout the world, the stigma against people living with HIV in Malaysia is still very much alive. So I think I quote Prof. Iskandar, which is one of our panelists before, that he says 41% of newly diagnosed patients has CD4 count less than 200, reflecting delay in seeking treatment and perhaps due to fear of stigmatization. From the kidney side, in Malaysia, the first kidney transplant happens in 1970s. Okay, people living with HIV was initially excluded from being the transplant recipient, and only recently, probably the kidney transplant involving the recipient with HIV being accepted recently. And from the dialysis side, it is generally well known that when you're diagnosed with end-stage kidney disease, the HIV patients can only do peritoneal dialysis, limiting the options of renal replacement therapy. And this is only happening in Malaysia. None of the private hemodialysis centers in Malaysia offer slots for HIV patients, despite the risk of transmission we know is much less than hepatitis B and C. So enough with that. So that's just introduction, just to tell you that, you know, our two panelists will be discussing on these issues in the forum-like topic, but I will let them to give their presentation first. So our two panelists are both lecturers. So the first one is Associate Professor Dr. Peng. So he's a well-known transplant nephrologist. People all around the country was looking for him, but he stick to And he's also visiting consultant for transplant program in UITM. So, and he's also a contributor for hemodialysis quality and standard of KKM, as well as many publications and grant in kidney transplantation. And our second panelist is Associate Professor Dr. Raja Iskandar Shah. So he was an acting head of infectious disease unit in UMMC. He is currently the president of Malaysian AIDS Council and also an AIDS editorial board member. So without further ado, I think I'll let the floor. So the first one, I will call upon Prof. Eng to give his introductory lecture, about 10 to 15 minutes. And then I'll let Prof. Iskandar to give introductory lectures. And then if you have any question and answer, we can discuss after that. As regard to this important topic regarding HIV patients as well as kidney disease. So, Prof. Eng, I'll let the floor to you and you can share your slides. Thank you.
Right. Okay. Thanks, Hafiz, for such a kind introduction. So I'd just like to declare that I'm not a transplant nephrologist. I'm a nephrologist that with some special interest in transplantation. So there's actually a big difference between the two. But having said that, okay, I'm just going to talk a little bit about kidney diseases associated with HIV infections. So this will be from a nephrologist's perspective. And of course, my subsequent speakers, Prof. Iskandar, is going to talk from infectious disease viewpoint. So let me just start by, right, okay. So let me just start by just talking a little bit about what has actually happened to people with HIV over the years. And asking me to do this job has actually allowed me to have a better understanding. In fact, I'm actually very surprised especially looking at some of the publications, literatures regarding the outcome of patients or people with HIV. And as you can see here, I think thanks to the effort that's actually been made by the infectious disease team, so we're actually looking at a tremendous improvement in terms of patient survival. These are the patients with HIV, and in fact, the survival has actually improved quite tremendously since the introductions of this what we call ART or antiretroviral treatment. So if you look at the graph on the right side, what you can actually see is that with the introductions of this ART, the mortality rate has actually dropped down quite significantly. In fact, it's actually dropped down by as much as about 30% if you are compared, to the eras without ARTs. And the other interesting thing that's actually noted, by looking at the statistics, is that now the life expectancy for people with HIV has actually, been has been very impressive, I would actually say so. With the life expectancy for the female in the regions about 76 to 77, and then the life expectancy for male is in the region about 74, 75. So this figure highlighting that we are looking at a group of patients that actually has done very well over the years, especially with the introductions of antiretroviral treatment over for the past few years. Right. Okay. So a little bit about statistics regarding the prevalence rate of chronic kidney disease. If you look at the diagram on the right, what you can actually see is that that's roughly about 40 million of HIV patients in the world at the moment. This is the figure that I've actually got maybe for about 2 years back. And most of these HIV patients, in fact, are found in the sub-Saharan regions. Okay, these are the regions where the prevalence rate and the incidence rate of HIV infections is extremely high. In fact, 70% of the HIV populations actually do come from these regions here. So, and if you look at Malaysia's the rate and the incidence rate and the prevalence rate of HIV infections, in fact, is I would say that is range in the low to intermediate level, with the prevalence rate ranging from 0.1 to 0.5% per year. So, and as you can see here, most of the literature reported or indicated that renal disease, the prevalence rate of renal disease in the HIV infected individuals vary geographically, right? So, and if you look at the literatures or data coming out from the Africa, showing that 6 to 48% of the HIV infected individuals has some degree of renal disease. However, interestingly, if you look at countries, for example, like Europe, Israel, Argentina, the HIV rate or the HIV-associated CKD rate, in fact, is very low, pretty low. It's about 3.5 to 4.7%. And closer to home, for example, like Hong Kong, the rate, the CKD rate, in fact, is actually about 18%. So there are many factors why to explain the variations in terms of prevalence rate in what we call HIV associated with property. In fact, it's multifactorial. And one of the most well-described factors that we know since the discovery of what we call HIV associated with property in 1984 is what we call a genetic predispositions. And this particularly true for what we call African, all right, for those Africans that who actually possess this genes, what we call L1 variant genes. If they do actually possess this gene, the risk of them having chronic kidney disease relating to HIV is actually extremely high. However, having said that, since this is a multifactorial the inductions or the cause is actually multifactorial. One that does require other factors, to induce some degree of kidney injuries. For example, types of the virus can actually be associated with increased risk of developing what we call high band or HIV associated nephropathy. Environmental factors, for example, like the use of the aflatoxins, nutritional aspect, co-infections. The most well-described co-infections that we know that can be associated with increased risk of developing chronic kidney disease will be something like hepatitis B infection, hepatitis C infections. But I think the most important factors that we must take into account is that access, as highlighted in this NEJM paper, is that access and adherence to combinations of antiretroviral therapy is utmost important. If the patient has access to medications and if he is compliant with the medication, the likelihood of developing HIV-associated nephropathy will be very much reduced. Okay, so when we talk about, as I mentioned previously about the multifactorial, the cause of the CKD-induced related to HIV can be multifactorial. In fact, it can actually give rise to many clinical phenotypes, right? So it can be broadly categorized into what we call acute kidney injuries or chronic kidney disease, as highlighted in these papers here. And of course, it can actually further be subcategorized into whether this is a pre-renal cause, whether this is an intrinsic renal cause, whether this is a post-renal cause. There are many reasons why kidney function deteriorate in a HIV patient. Now, once the diagnosis of chronic kidney disease is made, that I think as a responsibility of the nephrologist and the infectious disease physician is that we need to screen them regularly. Okay, first of all, we need to look for whether there's a presence of a chronic kidney disease or not, and we need to determine the staging of the chronic kidney disease. And depending on the staging of the chronic kidney disease, we need to manage them accordingly. Right. Unfortunately, with the advancement in terms of the heart, the better understanding in terms of the pathogenesis of the HIV-associated nephropathy, okay, the early referral to nephrologists for further management regarding the chronic kidney disease, some portions of patients still ended up with end-stage kidney disease. So as you can see here, but in fact, we're actually not too bad. But however, some portion of them still ended up with end-stage kidney disease, as reported in this paper here. The range of, or the incidence range or the prevalence rate of end-stage kidney disease among HIV patients, can actually range between about 0.4 to about 1.5%. So there's a certain number of patients still end up with end-stage kidney disease. However, this is actually not bad news for them, especially when they reach end-stage kidney disease, because this data here also indicated that, with the treatment of heart, the mortality, despite being on dialysis, okay, despite being having complete kidney failure, the mortality rate still much better compared to the eras without heart. Having said that, patients on dialysis, all right, HIV patients on dialysis, the mortality rate, they are still higher compared to patients without HIV on dialysis. So the hazard ratio, as demonstrated by these articles here, suggesting that HIV patients, the risk of developing the risk of dying is 3 times higher as compared to those not being on dialysis. Without HIV, sorry, not on dialysis, but without HIV. Right, okay, so what are the options? So I mentioned in the earlier slides that, now patients, the survival for HIV or patients with HIV are actually very much better now, right? So if they do reach end-stage kidney disease, what are the options that we normally offer as a nephrologist? Normally there are 3 options, just like any other population, 3 or 4 options. just like other populations. So we offer them the options of doing hemodialysis. Peritoneal dialysis is another option for as a form of renal replacement therapy. Kidney transplantation as another one. And of course, last but not least is conservative or palliative care. So I took this, this recommendation, in fact, from KDIGO, our KDIGO guideline regarding HIV positive individuals. So the most important message that I want to actually highlight for these slides is that, okay, HIV sero status should not influence the candidacy for kidney replacement therapy, meaning that HIV patients, once they reach end-stage kidney disease, they should be given the options, the freedom to choose whatever form of dialysis that they want, all right? Without us giving them, being biased, and this is something that I would like to highlight. And the other thing that I actually like to point out is that when we talk about dialysis, when we are when we counsel patients regarding renal replacement therapy, one of the things that we will need to highlight to the patients is that, in fact, there's no difference in terms of mortality when we are talking about hemodialysis or peritoneal dialysis. Both of them will give the patients the same outcome. So it's a matter of personal preference. And the other thing that I will actually highlight, of course, is that no kidney transplantation in HIV is in fact the standard of care as of now. Okay, so in fact, I think transplantation for HIV patients has been actually performed for the past more than 10 years already. In fact, more than 15 years already. They do give an excellent outcome, and this is one of the articles suggesting that if you have a successful kidney transplantation, the outcome for HIV patients is so much better as compared to those HIV patients being on dialysis. So, and there are a few issues that I would like to talk about, but I would just end with my last two slides here regarding this so-called group of HIV patients, the problem, the dilemma that they actually have. So this is one of the articles that was from Doris Jeff, okay, one of very famous transplant surgeons in America. So reporting that, despite, okay, a very well-established systems, in looking after patients with HIV being on waiting list for kidney transplantation. So what he has actually noted based on the American registry data is that HIV patients, okay, if you are a HIV patient, the chance of one getting a successful disease donor transplantation is less, okay, and more so if the HIV patient is actually to opt for living donor transplantations. So he has actually highlighted that this is actually the plight of the HIV patients that's being faced in America. The other things that I'd like to highlight is another article that's actually, this is one of the commentary that was published in the NEJM, stating regarding the problem that's actually being faced, okay? So a lot of problems that, a lot of decisions we make is actually because we don't understand that much about AIDS. So as you can see here, this what he actually reported that, in the early eras of HIV infections, so there was a lot of misconception, misunderstanding regarding the AIDS itself. So in fact, there are a lot of dialysis centers in US in the early eras of 1980s and 1999s refused to take in patients for hemodialysis. So, and this has actually highlighted that, human factors, healthcare factors, regulatory environment factors play a very important role how we actually manage patients with HIV. And I would just like to end my slides by talking that fears, in fact, is actually our biggest enemy in clinical medicine. And most of the time, it's actually due to ignorance.
All right, thank you very much, Prof. Eng. So we can see a little bit of your stand as regard to HIV patients in hemodialysis. By the way, we'll talk about it later after Prof. Iskandar's talk. So I give the floor to Prof. Iskandar to give his introductory lectures. Thanks.
Sorry about that just now. Thank you very much, Prof. Hafiz and Prof. Eng, for allowing me to be part of this agenda, and I congratulate the team at UMMC for raising this agenda. This has really been a topic for discussion over the past couple of years, and an agenda which I've been sort of pushing slightly. So I'm ecstatic that this has resulted in a discussion for the World AIDS Day of this year. So I'm just going to go through a number of slides very quickly, just to give a background of the HIV epidemiology in Malaysia, and then touch on some issues which will lead to the points of discussion subsequently. So we have about currently 67,822 people living with HIV, as reported to the Ministry of Health as of 2021. And the number of HIV infections over the past couple of years have been on average varying between about 3,000 to 4,000 number of infections each year. This is a snapshot in 2021 with about 2,760 infections, and this is lower in 2021 and expected largely due to a decrease in accessing healthcare services and HIV testing as a result of the COVID pandemic, which has happened in the past 2 years. So this is what we were talking about earlier on. The number of infections since 2010 have sort of plateaued around, on average, about 3,000 to 4,000 infections per year. And this is largely because of the change where it peaked in 2002 was largely because of a very successful harm reduction program with the introduction of opioid substitution therapy and a needle syringe program in an epidemic which was initially driven by injecting drug use. Sexual transmission, however, has been the predominant route of transmission over the past 10 years, with the majority of transmission now occurring in men who have sex with men. And the epidemiology of HIV in Malaysia is largely that it's concentrated within key populations. And this is of increasing concern, although this is outdated data as reported by the Integrated Biobehavioral Surveillance performed by the Ministry of Health in 2017. This was repeated this year, and we're waiting data for that. In terms of coverage, and we talk about renal disease, one of the best ways essentially to prevent HIV, of course, is to start antiretroviral therapy as soon as possible. And now currently recommendations are to start as soon as a person is diagnosed with HIV. But there's a lot of room for improvement in Malaysia, even though, and this is data reported once again to the Ministry of Health, 83% of people living with HIV know their HIV status. This dips significantly when you look at the coverage of the number of people who start antiretroviral therapy. And this is largely due to access to services, perceived and experienced stigma by people living with HIV who remain very much concerned or very concerned about access to HIV services and concerns what healthcare providers how they might be treated. And when you break this down into terms of key populations, overall, this does very poorly. Once again, this is data from 2017. 42% of key populations receiving antiretroviral therapy. So key populations being defined as the persons who are at increased risk of HIV. And when you look specifically at certain key populations like people who inject drugs and sex workers, they do tend to perform even more poorly. Late HIV diagnosis is a common, unfortunate result or presentation in Malaysia. So the estimates of people who are diagnosed with a CD4 count of less than 350 sort of remain very high, so up to 65% in 2021. So patients continue to present late, once again due to a combination of delay in access, concerns around HIV testing, concerns around perceptions by healthcare workers. But this is not unique to Malaysia. This is across the board, across Asia Pacific. So this is something that we certainly need to improve in terms of our public health interventions to get people living with HIV to come and present and get tested sooner. Now, HIV, and I think this is something that Prof has repeatedly mentioned, I think we don't do a job generally as a whole in terms of educating our colleagues in terms of how antiretroviral therapy has revolutionized the management of HIV, so much so that it has become a chronic manageable disease similar to diabetes. You've seen the life expectancy data from Prof. Peng, and this is data from a resource-limited setting in South Africa, where shows similar data that the life expectancy of people living with HIV, particularly those who start antiretroviral therapy at CD4 counts of greater than 200, approximate or are nearing towards the life expectancy of that of the general or the HIV negative population. Therefore, there is no reason why renal replacement therapy, be it dialysis or renal transplantation, should be contraindicated or not be given as an option to persons living with HIV. Now, when we think about concerns about HIV transmission, HIV transmission transmits actually not as high as you would think. And if you look at the needle stick injury rate of transmission is in the order of about 0.3%, which is lower than that of certain types of sexual intercourses. And so our fear of HIV transmission tends to be overinflated generally. Of course, if you transfuse 1 unit of HIV blood to another person who's HIV negative, that carries a significant rate of HIV transmission. But from occupational exposure itself is much lower than you would expect. And this is this is about 10 times lower than that of hepatitis B and hepatitis C comparatively. But we are in the era of U equals U, which essentially means undetectable equals untransmittable. And so people who take antiretroviral therapy for HIV as prescribed and who achieve and maintain an undetectable viral load, and a viral load essentially is the amount of HIV that can be detected in the blood by a lab assay, cannot sexually transmit the virus to an HIV negative partner. So essentially people living with HIV on antiretroviral treatment, there is no risk of HIV transmission. And this is a global movement to raise awareness amongst healthcare professionals, largely driven by people living with HIV, academics, and people who work in the realm of HIV. The message needs to get out because it affects how people living with HIV are treated as well in the healthcare setting and have the potential to reduce stigma associated with this vulnerable population. And the evidence of U equals to U is embedded in very strong science, essentially in 1 randomized controlled trial and 3 observational studies looking at 125,000 condomless sexual acts. And when they looked at this in this setting, there were 0 linked HIV transmissions between a HIV positive partner who had an undetectable viral load to a HIV negative partner in the setting where persons had sex in the absence of a condom. So the power of U equals to U essentially means that we no longer need to be concerned about risks of HIV transmission in the setting where the viral load is undetectable. And Prof has talked about similar dialysis outcomes between HIV positive and HIV negative on hemodialysis in the antiretroviral therapy era. In some data, there is a difference, but this is largely attributable to HIV-related factors such as CD4 count. Now, traditionally within Malaysia, and certainly for the past good couple of years, and certainly when I came back from the UK, I was very surprised that not just in UMMC, but across most hospitals in Malaysia, there was a lot of patients who were diagnosed in the setting of HIV and approach end stage with disease were not given the option of hemodialysis and peritoneal dialysis as options for their renal replacement therapy. Forget about even renal transplantation. A lot of patients were recommended that really peritoneal dialysis was the only option that they could choose as an option for renal replacement therapy. And this was very odd. And this is looking at guidelines. And if you look at guidelines, and this is guidelines from CDC, and we're going back more than 10 years ago, it clearly says that infection control precautions recommended for all hemodialysis patients are sufficient to prevent HIV transmission between patients. So these are standard universal precautions. HIV-infected patients do not have to be isolated from other patients or dialyzed separately on dedicated machines. And because HIV is not transmitted efficiently through occupational exposures, reprocessing dialyzers from HIV-positive patients should not place staff members at increased risk of HIV infection. So we're going back to more than 10 years ago, yet these practices continue, and it's baffling that the reasons. And I think when speaking to nephrologists, they do come up with some plausible explanations, but not plausible other than these outdated fears of HIV transmission, which are inflated from, the messages that were passed on about the risk of HIV transmission for more than 30 years ago. And so this is something that really needs to be addressed initially, I think, as a point of discussion, not just within UMMC, but nationally as well. And so the question is, why does this happen? And we know that stigma exists. We know that stigma exists towards people living with HIV for a long time. It's not unique to HIV. People with mental health disorders, for example, are increased risk of stigma within the hospital care setting. But what was surprising from this particular publication by the stigma group within our setting was that people a lot of healthcare workers believe that people living with HIV do not deserve good care. And they express a lot of negative feelings towards people living with HIV. But this is largely driven to fear of HIV. Surgeons were more likely to exhibit discriminatory behavior than a medical profession. And really, so this needs, once again, to be addressed. It's not unique to HIV, as I say, but stigma does exist, and it does prevent a vulnerable group from accessing HIV services. I just want to end, and this is my last slide. So kidney transplantation should not be a contraindication to people living with HIV. And I think we'll talk more about this. And this is, although this was a publication done in Thailand in 2021, where they were able to form their first HIV transplantation and published it, we should not, this really should not be, as I was mentioned, a contraindication as an option for renal replacement therapy, because outcomes are similar and mortality significantly reduces compared to dialysis following transplantation of HIV. And so I hope this leads to the more discussion around how we can increase this and put this as an agenda within the nephrology unit in UMMC. And so that's my last slide. I'd like to thank Hafiz and Prof. Peng for the opportunity.
Thanks, Prof. All right, okay, so let's call upon the two panelists. So we have another about 25 minutes to discuss this. I know that, this is within UMMC only, but I think this is important because the issues need to be addressed, at least locally first. So first of all, my question to Prof. Iskandar about terminology, right? So I'm always afraid, did I say it right? So the people living with HIV, is it correct to say if I mention patients with HIV, or is it not, politically correct nowadays to say that?
I think patients with HIV, okay. I think we're becoming more aware of our terminology at the expense of inducing more stigmatizing behavior towards a vulnerable population. I don't think patients with HIV are fine. I think we're trying to move away from terms like HIV infected people. So I think you didn't use those terminologies. So I think that would be completely, I think that's completely acceptable within the community. Hafiz.
Great. So another thing is about terminology. When I came back as well, I think people replace the word HIV with RVD. And I think, to quote Albus Dumbledore from Harry Potter, so he says that call him Voldemort, Harry. Always use a proper name for things. Fear of a name increases fear of a thing itself. So is that similar if, RVD, or we should be using HIV instead of RVD?
I think I use retroviral disease myself when documenting, and this is largely out of practice and out of something when you move to a place where it becomes more acceptable to use a term when you feel that the reason behind it being used is really to protect that population, because you're not making it apparent that they have a very stigmatizing disease. So you can understand why we would do that. But I think, personally, I think we need not to pretend that HIV is something else, I personally feel that we need to address the level of stigma within healthcare settings and develop interventions to reduce that, rather than use terminology which is similar but slightly different. So I think personally, if I would choose HIV, but what I have done in the past was really adopt practice which was particular to that specific setting. Yeah. So I think ultimately, in order to reduce stigma, I think we should probably use HIV and not use another term.
Okay.
So
thank you.
I would just like to echo what Hafiz actually talked about, because when I was reading a lot of literature, so I think that's actually started to use, instead of HIV patient, is patient with HIV or people with HIV. So does that make a difference, in terms of stigmatizations, or does it really matter at all?
Yeah. So a lot of persons living with HIV are well, right? And they're on antiretroviral therapy treatment, and they're thriving on their antiretroviral treatment. So I don't ever use patients living with HIV. That's a personal preference. And I like to, I think majority of us who work in ID like to depict people living with HIV as well patients, because they have this disease, which they have this infection, but they're doing well despite treatment. I personally would use persons living with HIV, but I don't think patients per se are discriminatory as such. I think if you use infected, terms like infected with HIV is more stigmatizing rather than using patients, in my opinion. Others may differ, but we are very conscious of the language that we use. And I think the very fact that we're talking about this is also very interesting, which also implies that outside the ID field, that other colleagues are also trying to reduce potential stigmatizing behavior towards HIV, people living with HIV.
Yeah, before we talk today, I was actually debating myself, whether to use people or patient with HIV. That this is actually one of the considerations I thought about, before, whether this is something that, as you say, whether this is discriminatory or not. So, but patient is okay for you? So you think that patient is all right? Yeah, patient with HIV or people with HIV.
Yeah, I think it's okay, but I would prefer to use persons living with HIV.
Prof, I think another part as well, we can be stigmatizing if we don't have good intention as well. I think the intention is good as well. People can use HIV, but still have a stigma. So, I think the core of the idea is, but anyway, directly question to you, to the heart of the matter. Why do you think in Malaysia that, people living with HIV is not being given option of hemodialysis, despite what we have learned just now?
Yeah, I think that my second last slide has actually has highlighted that there are actually a lot of fears, as mentioned by Prof. Iskandar also. A lot of us, aside from infectious disease team, that will have actually quite an in-depth, understanding, and mentioned about patients who actually has non-detectable level of these HIV viruses. The risk of transmissions is virtually, very low. So, but I think this sort of information may not be disseminated to, most of the dialysis centers. And please bear in mind that, a lot of dialysis centers are actually, run by run for profit reasons. I have to say that, and then having patients, okay, with HIV, you know, coming to the dialysis center, okay, to receive treatment, potentially may drive, you know, that's the problem, is that they drive other patients away. So I think this is actually one of the reasons that's why I think that, you know, that why a lot of dialysis centers, they are actually not keen to, you know, take on patients with HIV. But I'm sure that there are actually more reasons than that. I think the other thing, of course, is that if you look at the current guideline from KKM, if you want to take on a patient, okay, who has HIV, so you need to isolate the patient, meaning that you need to have a specific slot, specific machines that's reserved, you know, for people with HIV. So potentially, you know, it can actually incur increased cost of running the center, because you need to have a machines, you know, to cater for, you know, this group of people, and it may not be, you know, economically, you know, viable or feasible. I think this is actually part of the reasons. But I think there are many other reasons, I think, that potentially may explain why that is the case. For example, like what will happen, you know, if there's outbreak of transmission, even though that, you know, the reported case of outbreak in the dialysis centers are very rare. But having said that, there's always a fear. You know, the point is that fear. You know, you always worry that, you know, something might happen, something disastrous may happen. And what if that happens? What will happen to the dialysis centers? You know, they always take into considerations and things like that. So yeah.
Okay. Prof, I know you want to say. So I will let you say. But you see, I just want to add one point. Even if the nephrologist community agrees that, you know, HIV can go for hemodialysis, but we are living where we are not in control of a hemodialysis center outside. And a lot of businessmen who, you know, do all these private centers, they are the one who have sometimes the final say of, you know, whether to include the HIV patients or not. So now you say.
Thank you very much, Hafiz. I think, you know, you start everything with baby steps. And I think when you talk about something like this, the thing to do is to look at your own center and maybe just start there. Let's forget about outside private centers. But I think I understand the idea behind changing national guidelines. So if the national guidelines state that people living with HIV should not be need to be isolated, then that also needs to be addressed as nationally. But that needs to be based on solid concerns around the risk of transmission, risks of HIV transmissions through hemodialysis, and patients not being isolated. Now, there have been very, very, very few case reports or case series of HIV transmissions through hemodialysis, and they have been published. I think there's one in Egypt and one in Saudi Arabia, and largely those have been due to breaches in infection control practices. So I think overall, the question is, do your own kidney association guidelines, the KDIGO, I think, also do not recommend that you need to. They don't recommend isolating HIV positive patients as such, or having to use separate machines, as similar to the CDC. And I think that the question about stigma has repeatedly been brought up. So you need to then look back at your own inherent practices and whether some of this is also being driven by that. You know, it takes a leader, it takes a leader to an advocate and a person who's passionate about it to make changes. At least this discussion is continued. I'd like to see this discussion continuing and see how we can potentially change it, at least within the local setting first, and then subsequently beyond.
Prof Eng, just to follow with what Prof Is was saying, right? Something needs to change. But before that, do you know, Prof Lim was asking whether you have some statistic of people living with HIV infection who have end-stage kidney disease in Malaysia itself. Do we have some statistics on that?
I've been looking for the statistics also. I actually have to admit that, you know, the only thing that I was actually able to find out is that, you know, the only centers, or there are only few centers that are offering hemodialysis for people with HIV. So one of the main centers is actually in Sungai Buloh, and there are a few other centers that I've actually got to know about. It's in Johor Bahru, and I think for UMMC we are actually offering a regular dialysis for one HIV patient. And this is
And
actually,
they're all kind of government centers, not private
it's,
centers.
yeah, it's government centers. Most of these are government centers. I don't think that any NGO centers or any what they call those privately run centers, they offer like no hemodialysis for HIV patients.
Okay. And to continue, Prof. Lims was asking, any initiative to change the paradigm among us nephrologists and physicians managing HIV and kidney disease? Because you want to dialyze them in center, but it's not you only who needs to change. The patients, the stigma of patients needs to change. The businessman or whoever is the nurses who's dealing with the centers need to change. The CCAPs and the guideline, all those things. So a lot of layers. What do you think?
Are you asking me?
Yeah. So both of you.
Yeah.
I was thinking.
I think the nephrologists, okay, most of us would actually know that, there's no need to, isolate patients, HIV patients, especially if they are being on dialysis. It's a question of how to go about implementing this. And of course, I think Prof. Iskandar has already highlighted, this actually requires changes, at the top level, and how we can actually implement it, at the ground level as well. So, of course, I think the input from infectious disease experts is highly important in this aspect, especially regarding the risk of transmission, and I think this is something that we may need input from the infectious disease team, and advising the nephrology, the nephrologists regarding, how we should actually go about changing the policies, especially, in regards to hemodialysis. Yeah.
Okay. Prof. Yes. And can address Prof. Sarah's question as well. Should be part of the law, non-discriminatory law. Should we use that?
Absolutely. Thank you, Prof. Sarah, for mentioning that. I think, I think we have a lot of issues around stigma and, people living with HIV. I mean, there's a lot of work to be done, but I think a priority for us should be within healthcare settings. But I just want to go on the record to say that Prof. Peng did say that we are aware that people living with HIV do not need to be isolated in terms of from dialysis. So that's good. We have it on record, and I'm very glad to hear that, which means at least we can move forward with those discussions. And then to admit that and say that, then the next step is to really to do something about it. Can I just also emphasize, and I think some people are bored of me saying this completely, in the setting of U equals to U, so somebody who's on antiretroviral treatment and undetectable, you cannot even pass the HIV at all through sex without a condom. Of course, we have less data on occupational exposures, but this can be extrapolated. All this is based on our theoretical risk of a potential risk of transmission, which is hugely outdated and based on the fears that were set 30 years ago. We really need to move forward and at least meet what people are doing in settings outside Malaysia. The other thing is, I think, are we supposed to keep our wraps on Hafiz and Prof. Peng about what happened recently in the unit in terms of renal transplantation? How come we're not sharing that to the UMHealth? Are we supposed to keep
Prof. Peng, I'm okay. I'm very open for that. But I think we have to get Prof. Lim as well on board.
I don't have any. I don't have any, objection to that. I don't have any objection to that.
Prof. Ace, just in case that we want to declare in a more kind of a sophisticated manner. So I think that was the question.
Okay, but then that's fine. That's under wraps for now. That's entirely up to you. But I mean, okay. I just think that the nephrology team and the transplant team deserve, a big applause, and this is a potential platform to be able to highlight that.
Okay. Prof, you have been, I mean, HIV community or the infectious disease community, when you talk about HIV, everybody knows about it, right? It's just like breast cancer, everybody knows it. So, maybe us, the nephrologists, can learn a bit and pieces from the tactic of infectious disease and people living with HIV on how to promote or reduce the stigma of this in the nephrology community. What was done?
I think probably not as much as can be done. I think because the setting from where I came, which was in London more than 10 years ago, there was already an established renal transplantation service for people living with HIV already. And they were also included in the National Registry of Transplants, so they could receive donors from the donors which are unrelated to somebody related to them, and also hemodialysis was also an equal option to peritoneal dialysis. So that was already established. I think it's one way which my colleague Dr. Wong is really trying to do a lot of excellent work in is to really reach out to form multidisciplinary clinics with various specialities, so including geriatrics, renal, and endocrine as well. And I think some of these multidisciplinary discussions can serve as benchmarks for other specialities where you discuss issues around this. So one, in terms of clinical care, but also, I think the message around U equals to U, I think in the last 3 or 4 World AIDS Day celebrations that we've had, we've used the theme U equals to U repeatedly. So to the point that we would feel that our colleagues at least have some idea of U equals to U and the risks of transmission of HIV in the setting of an undetectable viral load. Yet I think at the same time, it's not reaching. So we really need to think of other ways. I think a more personalized contact, regular contact with the team would help and go a long way in terms of trying to, address some of the issues that we're discussing today.
All right. Okay. We have another 5 minutes. So I think we just address quickly the question by Prof. Lim, Prof. Chan. So Prof. S, do you know anybody with HIV who basically, because they want to do hemodialysis, they have to kind of go elsewhere for short-term doing dialysis? Sure.
No, because in terms of no, I think most patients, I think a lot of the time we are guided by the counsel that you provide them. And I think ultimately, I've not known patients who've been refused here, if that is a question, managed to get it elsewhere. I think maybe there's 1 or 2 private centers which have accepted that, but largely a lot of these patients do not have income which would allow for that. And so they tend to just agree with the counsel which was given by the renal physicians here.
And Prof. Lim was asking any approach to reduce the occurrence of CKD among people with HIV.
So, you have a combination. So if I can just chime in very quickly from a HIV, you have traditional risk factors, of course, like diabetes, hypertension, and also, of course, you have the HIV-related factors, which is low CD4 count, high viral load, and certain ongoing chronic inflammation, which is responsible for comorbidities in people living with HIV, and of course, antiretroviral induced nephrotoxicity. I think where we can do better is in terms of trying to get patients to get diagnosed early so that they present at an earlier stage, because we know that low CD4 count is associated with worse outcomes in people living with HIV and progression to end-stage renal disease. So getting people to start treatment as soon as possible is one way.
All right, okay. So for final say, I think I'll get Prof. Ng to say a quick word, probably for 1 minute or so. Just a conclusion, and what's your hope, Prof. Ng?
My hope is, I think, as mentioned by Prof. Iskandar, is that, we should offer, allowed HIV patients the freedom of choose whatever they want in terms of renal replacement therapy once they reach end-stage kidney disease. And of course, I'm hoping that we can actually offer kidney transplantations as part of the renal replacement therapy for subsuitable candidates. Not all of them, but subsuitable candidates with proper donors, and So this is what I hope to achieve.
Okay. All right. So back to you, Prof. Although your name is Prof. 1 Ahmad Hafiz, but anyway, Prof. Raji Iskandar, please, yes, your conclusion.
So my conclusion is I'd like to nominate Prof. Peng and yourself, Prof. Hafiz, to lead this movement. I think this discussion is very timely, and I think the very fact that you have that you've made this your agenda this year is it's fantastic. And I think with HIV, and like with everything else, all of us who work in ID, who work in the area of HIV, become advocates for a vulnerable population, and we become a better person as a result of it. So I think what I've heard from both of you today has been very exemplary, and I think you could be ideal advocates for pushing this agenda forward, along with us, of course. But we need to partner with nephrologists. But we also need to move the barrier with renal, not just with hemodialysis, but with renal transplantation as well. And I think I look forward to the more formal press release of that. And a big thank you once again to you guys for really moving that agenda forward.
All right. With that, I really thank both our panelists we have an excellent discussion. I enjoy discussion very much. And thank you for those who are asking questions and making this discussion more lively. And with that, our World Kidney Day is ongoing. Tomorrow we have celebration, all those things. So thank you very much, everyone. And hopefully we'll meet again next year for WKD 2024. Thank you very much. Assalamualaikum.
Thanks again. Walaikum salam.